Today we're getting into a really demanding medical topic. Blast trauma protocols for healthcare providers.
Our goal today is, well, straightforward navigation of blast injury. Being truly prepared here means understanding those dangers that aren't immediately obvious. So what makes blast trauma so unique in emergency medicine?
It's really the complexity, I think, in the unseen forces. Blast trauma is this devastating event that comes from a huge, incredibly rapid release of energy. But unlike, say, a straightforward impact injury, the real immediate threat often comes from something invisible.
The pressure wave.
Exactly, the pressure wave itself, not necessarily the fire or the debris or the shrapnel that you see right away, though those are obviously serious too.
Right. And the path to managing this correctly, it seems, absolutely starts with understanding the underlying physics. If you don't grasp how that blast wave works, you're just chasing symptoms, aren't you? Not the root cause.
Precisely. So our objective here is to lay out the essential knowledge on the mechanisms, the classification, focusing particularly on identifying those silent injuries.
Silent injuries.
Yeah, the internal damage that might leave absolutely no visible mark on the outside of the body, but can be immediately lethal.
Okay, let's unpack that physics then. A high-order explosive detonates. How does that create the initial moment of injury?
Well, you can think of it as a kind of two-act event, starting with these extreme pressure dynamics. The detonation creates a supersonic wave of compressed air. We call this the positive pressure phase.
Okay.
And it's marked by this immediate, very sharp spike up to what we call the peak overpressure.
That peak overpressure. That sounds like the point of maximum force, maximum destruction. How intense are we talking?
Oh, it's staggering.
Yeah.
The pressure increase in that fraction of a second can surge way beyond normal ambient atmospheric pressure multiple times over. Depending on the explosive, the distance, you could be looking at hundreds of pounds per square inch. This pressure spike travels out like a shock wave, incredibly fast, supersonic. Anything in its path that isn't, heavily reinforced gets compressed, twisted, potentially ruptured.
But it's not just a simple push outward, is it? There's that other force, the sort of counterintuitive one that follows immediately.
That's right. That's the second act, the negative pressure phase. As that initial high pressure wave expands and moves outward, the air rushes back in to fill the temporary void that's left behind the wavefront.
Oh, okay.
This causes the local atmospheric pressure to actually drop below the normal level for a brief period.
So instead of a push, it's more like a pull, a kind of vacuum effect. What does that mean for the patient clinically?
Well, that vacuum effect, that negative pressure, is problematic for a couple of reasons. First, it sucks air and debris back inward towards the blast's epicenter. This is sometimes called the blast wind.
And that can cause injury, too.
It can.
Yeah.
It might cause a second impact, like a secondary blunt force trauma. But second, and this is really important, if the initial blast created any open wounds, this negative phase can literally suck dirt, bacteria, debris back into that wound cavity.
Leading to severe recontamination.
Exactly. So an explosion is really defined by both that initial compression and the suction that follows it.
Understanding that dual mechanism, the push and the pull, seems critical. Which brings us to categorization. We need to classify the damage. Why is using the 5 injury mechanisms so essential for a clinician facing this in the trauma bay?
Classification is, well, it's like our roadmap. It prevents us from getting tunnel vision, focusing only on the really dramatic visible wounds, the bleeding, the fractures, and missing the potentially fatal internal damage from the pressure wave itself. If you only treat what you see, you will miss primary injuries.
Okay, let's detail those 5 types, starting with the one directly linked to the physics we just covered.
Right, that's primary injury. This damage is caused directly by the blast overpressure wave hitting the body tissues. Because the pressure wave travels differently through air compared to fluid or solid tissue, it creates these massive shear forces at the interfaces.
Interfaces, like where air meets tissue.
Precisely. That's why the air-filled organs, the lungs, the gastrointestinal tract, and the ears are the most vulnerable to primary injury.
So the pressure wave itself is acting like a weapon. What about the more obvious weapons, the projectiles?
It brings us neatly to secondary injury. This is the damage from flying fragments and shrapnel propelled by the blast energy. Think debris, bits of the device casing, glass, rocks, wood, anything turned into a missile.
Okay, so penetrating trauma, lacerations.
Exactly. Penetrating trauma, deep lacerations, even traumatic amputations. The severity here really depends on the mass and the speed of whatever hits the person.
Then there's the situation where the person themselves becomes a projectile. That must add another layer of complexity, especially with orthopedic injuries.
Yes, that's tertiary injury. This happens when the blast wind, that outward rush of air, actually lifts and throws the entire body.
Wow.
The injury occurs when the person then impacts a solid object, a wall, the ground, a vehicle. Clinically, this looks very much like high-speed blunt trauma. You see severe bone fractures, major joint dislocations, and often intracranial bleeding from the impact.
Okay, so primary is the wave, secondary is projectiles, tertiary is being thrown. The next two categories cover other consequences, maybe less direct but still serious. What falls under quaternary injury?
Quaternary is kind of a catch-all category for all the other immediate, non-mechanical injuries caused by the explosion or its effects on the environment. This includes things like severe burns from the heat flash,
Flash burns, okay.
asphyxiation from smoke inhalation or toxic gases released, crush injuries if a building collapses, and exposure to harmful substances like carbon monoxide or even heavy metals from the device.
And finally, there's a category for things that might not show up right away. Delayed effects.
That's quaternary injury. These are the illnesses or conditions that develop later, sometimes days or weeks later, resulting from exposure to unconventional contaminants released by the blast. Think chemical agents, biological agents, or radiological materials.
Like in a dirty bomb scenario.
Exactly. A dirty bomb introduces a significant quaternary risk, and that requires specific decontamination protocols on top of everything else.
Okay, let's really focus now on primary blast injury. You called it the silent killer. Which organs are most vulnerable to this direct pressure wave damage, and why them specifically?
Again, it's the air-filled organs. Because of what we call acoustic impedance mismatch at those air tissue boundaries, the pressure wave travels very differently through air than it does through denser tissue or fluid. This difference creates huge shearing and tearing forces right at those interfaces.
So lungs, ears, GI tract, priority number one for assessment.
Absolutely.
Let's drill down on blast lung. It's widely recognized as the most lethal primary injury. What exactly happens pathologically that makes it so deadly?
Well, blast lung is the single most common cause of death, directly from the primary blast wave. What happens is the pressure wave physically ruptures the tiny air sacs in the lungs, the alveoli, and it tears the walls of the small blood vessels, the capillaries, surrounding them.
So bleeding into the air sacs?
Massive alveolar hemorrhage, yes. The lung tissue essentially fills up with blood and fluid leaking from those damaged capillaries. This leads very quickly to severe pulmonary edema fluid in the lungs, a profound mismatch between ventilation and blood flow, and often intractable hypoxia, meaning dangerously low oxygen levels that are hard to correct.
And beyond the bleeding and the edema, there's another, perhaps even more immediate and fatal threat tied to this alveolar damage, isn't there? What is that consequence?
Yes, there is. It's arterial air embolization. This is critical. The force of the blast can rupture those air-filled alveoli and literally push air directly into the pulmonary venules and the small veins carrying oxygenated blood away from the lungs.
Air getting into the bloodstream.
Exactly. That air travels quickly to the left side of the heart and then gets pumped out into the systemic circulation. If those air bubbles lodge in the coronary arteries supplying the heart muscle,
Immediate heart attack.
immediate myocardial infarction. Or if they travel up to the brain,
A stroke.
an immediate, often devastating stroke or seizure. This is a critical, time-sensitive emergency that needs to be considered and addressed right away.
This really underscores the need for a high index of suspicion. Now, historically, I think clinicians sometimes used a quick ear check, right? A ruptured eardrum was maybe seen as a sign of significant primary blast exposure. Is a ruptured tympanic membrane actually a reliable indicator of how severe the internal primary injury might be?
No, absolutely not. And this is a really crucial point. It's a sort of paradigm shift in how we approach this now. While ruptured eardrums or tympanic membranes are incredibly common because the middle ear is air-filled and very sensitive, the absence of a rupture tells you almost nothing reassuring about internal damage.
So someone could have a fatal blast lung, but their eardrums could look perfectly fine. Why is that?
Several reasons. First, the person's orientation relative to the blast wave matters. If their head was turned or if their ear canals were somehow shielded, the membranes might survive. Also, things like wearing hearing protection, even simple earplugs could protect the eardrum. Second, and maybe more importantly, the amount of pressure needed to rupture an eardrum is actually much less than the pressure needed to cause significant damage to the lungs or bowel.
Ah, okay. So the eardrum breaks relatively easily, but it's not a good measure of the overall energy exposure.
Exactly. It's not a reliable gauge for visceral injury. Someone can suffer catastrophic internal damage, severe blast lung, bowel perforation, even if their eardrums look perfectly intact on exam. So the clinical takeaway is crystal clear. Intact eardrums should never make a clinician less concerned about primary blast injuries. Everyone within that blast radius needs evaluation for internal damage, period. That's the fundamental triage paradigm shift. If they were in the zone, you must treat them as potentially having a primary blast injury until proven otherwise. You cannot rely on external signs alone.
Okay, let's move down the body, thinking about the gastrointestinal system. Which parts of the gut are most vulnerable, and what's the key pathology we're looking for there?
Again, it's the air-filled or gas-containing sections that are most at risk. Specifically, the colon, particularly the cecum and the ascending colon, and the ileocecal region where the small intestine joins the large intestine. The gas normally present in these areas creates those same susceptible air-tissue interfaces.
And the damage mechanism is similar to the lungs, shearing forces.
Yes, the pressure wave causes similar shearing, leading to microthrombosis, tiny blood clots in the small vessels within the bowel wall, intramural edema, which is swelling within the wall itself, and hemorrhage bleeding into the wall.
What's the immediate threat from that? The immediate threat is perforation, a hole straight through the bowel wall, leaking contents into the abdomen. But there's also a more insidious risk, delayed perforation. Delayed. How does that happen?
That initial microvascular damage and swelling can compromise the blood supply to a section of the bowel wall, leading to ischemia or tissue death. That damaged tissue might look okay initially, maybe just bruised, but it can then necrose and perforate hours or even days later, typically around 36 to 72 hours post-injury.
So that requires ongoing monitoring.
Absolutely. Serial abdominal exams are crucial, and you need a very low threshold for repeat imaging or even surgical exploration if the patient's condition changes or they develop abdominal signs later on.
Okay, and finally in this section, the neurologic effects. We've all heard the term shell shock from World War I, often linked to psychological trauma. What's the modern understanding of the physical basis for this?
Right, we now understand shell shock largely as the historical description for what we currently recognize as blast-induced traumatic brain injury, or BTBI. And the key point is that this is often a genuine physical injury to the brain.
Caused by the pressure wave itself.
Yes. The sheer force of the pressure waves can be transmitted through the skull, or potentially up through the major blood vessels connecting to the brain, causing direct impact and sheer forces on the brain tissue itself. It's a type of concussion, essentially.
So what are the kind of measurable neurocognitive symptoms clinicians should be looking for that point towards this physical BTBI beyond just the immediate concussion?
The symptoms can be quite profound and honestly sometimes overlooked in the initial chaos of managing severe physical trauma. We're talking about things like measurable cognitive dysfunction, problems with memory, attention, processing speed, also altered sleep patterns, chronic mood disturbances like depression or anxiety, significant problems with executive function planning, organizing, decision-making, and often retrograde amnesia, a gap in memory for the events right before the blast.
And recognizing these as potentially stemming from a physical injury, not purely psychological, is important for treatment.
It's essential for planning appropriate rehabilitation and support. Okay, let's pivot now from pathology to action. Clinical management and triage protocols. Time is absolutely critical here. What structured approach should guide that initial assessment when these incredibly complex multi-system trauma patients arrive? We have to anchor ourselves in the Advanced Trauma Life Support ATLS protocols. That remains the bedrock, the gold standard framework. However, in blast scenarios, the application needs to be flexible, tailored based on immediate clinical judgment. The primary survey ABCDE must be rapid, systematic, and focused on finding and treating the most life-threatening issues first.
Now, given that secondary and tertiary blast injuries often involve massive hemorrhage, maybe from extremities or junctional areas, how might clinicians need to adjust that standard airway, breathing, circulation ABC sequence?
This is where that pragmatic shift to circulation, airway, breathing, the CAB approach can be absolutely indicated. If you have a patient with obvious, massive, exsanguinating external hemorrhage.
Like arterial bleeding from a limb.
Exactly. Or severe bleeding from the groin or pelvis. In that situation, stopping the catastrophic bleeding must be the immediate priority.
So control the hemorrhage first, potentially even before securing a definitive airway, assuming the patient is still breathing somewhat.
Absolutely. If a patient is literally bleeding to death in front of you from a devastating secondary or tertiary injury, applying a tourniquet effectively, packing a wound, applying direct pressure, maybe even rapidly applying a pelvic binder, if indicated that it has to happen now, it precedes the potentially time-consuming process of intubation. The goal is to preserve the patient's remaining blood volume while you simultaneously work on the airway and breathing components. Life over limb, but also circulation first in massive hemorrhage.
Okay, that makes sense. Let's move to diagnostics, specifically confirming blast lung syndrome, the big killer. What are the pathognomonic findings, the really characteristic signs you'd look for on an initial chest X-ray?
On a standard chest radiograph, which is often the first imaging you'll get quickly, the classic pathognomonic signs are these bilateral, meaning on both sides parallel consolidations. That's whitening or opacity around the central area of the lungs, the hilum.
Okay.
And often you'll see diffuse ground glass opacities, kind of a hazy appearance, classically described as forming a butterfly pattern.
A butterfly pattern. Why that shape? Is that related to the physics of the wave?
It is, actually. The thinking is that the pressure wave enters the chest, travels through the lung tissue, but then reflects off the denser central structures, the heart, the major airways, and blood vessels at the hilum. This reflection concentrates the energy back towards the center of the chest.
Causing the most damage there.
Exactly, causing the most intense hemorrhage and edema in those parietal regions, which then radiates outwards, creating that characteristic butterfly wing appearance on the X-ray.
Is a standard X-ray usually enough, or do you really need more advanced imaging?
Well, the X-ray is fast and essential for initial assessment, but computed tomography, a CT scan, offers vastly superior detail. It's much better for characterizing the full extent of the lung injury, for identifying smaller pneumothoraxes, collapsed lungs that might be missed on X-ray, and crucially, for detecting signs of those dangerous arterial air emboli we talked about.
And what about ultrasound?
Bedside lung ultrasound is also becoming incredibly valuable. It's very rapid, can be done right there in the resuscitation bay, and it's excellent for quickly detecting pneumothorax and significant pulmonary contusions or edema.
Okay. Moving to airway and ventilation strategy itself. Beyond the standard trauma indications like inability to protect the airway or poor oxygenation, when should clinicians have a particularly low threshold for early intubation in blast victims?
Given the specific risks with blast trauma, you should consider early endotracheal intubation quite aggressively in certain situations, particularly if there's significant facial trauma, which can lead to swelling and obstruction. Also, evidence of severe inhalation injury from burns or toxic gases is a strong indicator.
Okay.
And also, if there's rapid neurological deterioration, perhaps suggesting evolving BTBI or intracranial injury, the key is not to wait for complete airway collapse. You need to anticipate the likely trajectory and secure the airway proactively.
Right. And once the patient is intubated, the way you ventilate them has to be carefully tailored to protect those already injured lungs. What are the absolute cornerstones of lung protective ventilation in these patients?
The absolute cornerstone, the non-negotiable principle, is using low tidal volume ventilation. We have to minimize the amount of pressure and the volume of air being pushed into those damaged alveoli with each breath to prevent causing further injury, what we call ventilator-induced lung injury, or VLE.
And what's the specific target volume?
You must target a tidal volume of 4 to 8 milliliters per kilogram of the patient's predicted body weight, not their actual weight. This is crucial for minimizing stretch and strain on the injured lung tissue.
But what's the critical danger or caution when applying PEEP in a blast patient who might have an undetected pneumothorax?
Yeah, you have to be extremely vigilant with PEEP because the damaged lung tissue might act like a one-way valve. Air gets into the pleural space around the lung but can't get out. Applying high PEEP can force more air through that leak, rapidly expanding the pneumothorax and potentially converting it into a life-threatening tension pneumothorax, which collapses the lung and compromises heart function.
So constant reassessment is needed.
Constant vigilance, serial chest exams, frequent chest x-rays, or using bedside ultrasound to actively look for signs of pneumothorax expanding, especially if you need to increase the PEEP. So if we try to synthesize all of this, the core message, I think, for managing blast injury is really about recognizing this cascade of insults. It demands an incredibly high index of suspicion from the clinician to actively look for and identify those silent hidden injuries, the primary blast effects, the occult bleeding, even when a patient might initially look deceptively stable.
Right. Which brings us to a final thought. We've discussed the complexity of blast-induced traumatic brain injury, the BTBI, and we know from extensive military and civilian experience about the significant long-term psychiatric consequences, things like chronic mood disorders, lasting cognitive problems, post-traumatic stress disorder. So given this link, we really have to ask ourselves, how should we fundamentally change our current hospital trauma protocols? Should we be incorporating mandated psychological screening and objective cognitive assessments right from the beginning, as soon as the patient is physically stable enough? enough. Making mental and cognitive health an integral part of that initial trauma evaluation, rather than just thinking about the physical injuries first and deferring the psychological and cognitive aspects to much later follow-up. That complex, patient-centered question is the thought we'd like to leave you with today.